Good afternoon, everybody. Welcome to our second informatics webinar entitled Using Information to Improve Connections Between People and Systems, which is sponsored by NCSD and CDC DSTD. As some of you know, we've started an informatics series sort of to go beyond our STD surveillance users groups to reach a broader audience and to talk about a little bit more topics than are system specific. Just trying to. Today we are pleased to have with us Dr. Nini Mishra from CDC, who's the informatics lead at the CDC Division of STD Prevention, Surveillance, and Data Management Branch, and Jim Ivey, Chief Executive Officer and co-founder of Checks Out, and to give us a real world experience on having cloud-based computing and using all the kind of the informatics tools that we all should be moving to. My name is Charlie Ravens. I'm a capacity building consultant with NCSD, and I'm going to be facilitating this webinar along with my colleagues, Talia Parker, who's with our program team, and Robin Hennessy, who's also with the CDC Division of Surveillance and Data Science Branch. Okay, having a little trouble with the slides. So a couple of housekeeping things. If you need to reach us, please use the chat function to talk or ask for help. We do have a separate Q&A function, and that's where we really would recommend if you have questions for any of our presenters. I would put those in the Q&A. I believe all the participants will be muted during this session, just so we don't have any interference, but we will address any questions that you have in the chat. If for some reason myself or any of our facilitators lose connection, just stay on the line till we reestablish. I think the whole system shouldn't go down, and I think we have backup, but we're dealing with technology, so anything can happen. We will be posting slides from today's webinar in the chat function in about 10 minutes, just because they show up a little bit later. And we will also be posting a recording of the video and the slides. We'll make those available on the NCSD website in about a week. So our agenda for today is I'm going to do some quick introductions, which I've done. Just a couple of minutes on informatics, past, present, and future. Dr. Mishra is going to give us sort of an overview and contextualize informatics and system modernization. And then the bulk of our session is going to be a discussion and actual demonstration from Checks Out, which is clinic management, surveillance, and contact tracing software and systems. And they've done a lot of work, especially recently with COVID-19. So I think they really have a lot to share with us about their experiences and sort of lessons learned. And then we'll close it out with just a couple of quick evaluation questions so we can make sure that we're reaching, providing you the information that you want. So a little about informatics, past, present, and future. As you probably could see from my picture, I've got a few miles on myself. I started STD prevention in the early 70s. And when I think back on my career of how far we have come around information systems and informatics, if you see on the upper top is a series of cards. If anybody can write in the chat if they know what these cards were called, these were actually how we tabulated data back in the early 70s. So they were punch cards. Each of those lines sort of on the left-hand side, you could ask for like race, sex, city, symptoms, those kinds of things. And if somebody had it, you would punch a hole. And then you would take one of these metal rods, and all the cards where somebody met that characteristics would fold out. So you can imagine if you were doing any kind of multi-analysis around, people in this age group, by this sex, by this race, who lives in this city, it was quite a tedious thing. And in the early stages in the 70s, we really hardly were just, it was kind of at the beginning of the computer age. If we needed to do anything, we really had to work with IT who would write the programs, and we would be working on punch cards, and it was just a very tedious process. Early 80s, personal computers became available, which really kind of provided us in the field with the ability to start manipulating data and really kind of created this whole new era where practitioners could actually work with their own data. And then here we are today with, in our hands, we have phones and text messaging systems, and really a computer that probably has as much power in that phone as you can see in that bank of computers in that room. So we've really come a long way. One of the things that we're really encouraged is if there's a bright side of COVID, and there's not very many bright sides, is that I think COVID has really kind of awakened the importance of public health to a lot of people, and the fact that for so many years, public health has been underfunded in this country, and especially around informatics and surveillance systems. And I think, as most of you know, there's been a lot of new money in Congress to help support public health, both to respond to COVID-19 and other infectious diseases. And so there are monies available and will be coming available pretty shortly in a number of different venues that will probably help people to improve their surveillance systems and improve informatics and enhance them. So as Dickens said, the worst of times, the best of times. So I think hopefully this webinar is going to sort of talk about kind of where we're at and where we're going. I just wanted a couple little things about today's webinar. We have a pretty good attendance. We had 211 persons registered, representing around 143 different organizations. 64% of you work in a state health department. 16% work in a county or city. So we're reaching the people that we really want to work, people that are actually doing the work out in the field. As far as what kind of job roles you have, about a quarter of you are in program management or leadership, about a quarter work in surveillance and epidemiology, about 12% in informatics and IT, and then we have about 17% of people in partner services and contact tracing. So we have a broad range of people on the call, which we're really glad to. And I think, especially when we get to the checks out demonstration, we're going to see that there is software that we're trying to tie all these different people doing all these different things back to our theme of connecting people to systems. A little bit about this is sort of where we're at today. One of the questions we asked was, does your program use texting to send messages or test results to clients? And about 2/3 of you said yes. So that's kind of promising that already 2/3 of you have adopted text messaging as a way of quickly getting results out to clients and doing other kind of communications. And then we have about 1/3 of you that we sort of need to bring up to speed, and hopefully, again, we're providing you some information today that might help you get there. Another thing we wanted to kind of get a feel for was we asked people to rate their capacity to assign, monitor, and evaluate DIS services using technology. I left that off the slide, but interestingly, about 30% of you or 35% indicated that you have a really good capacity, and almost half of you said you had a fair capacity. So I think it's encouraging that only 20% of people kind of rate themselves as only having a capacity of 1 to 2. But I think our goal is, in the next several years to get everybody up to having a 5. And again, hopefully today will be kind of a stepping stone to getting there. And then lastly, we wanted to get an idea of, does your program use cloud-based computing? And it looks like about 1/3 of you indicated you do, about 2/3 don't. And so Dr. Mishra and Jim are going to talk about sort of how to take advantage of cloud-based computing and how it works. So that's kind of my opening. I want to turn it over to Dr. Nini Mishra, who's the lead informatics person at CEC. So Dr. Mishra.
Thank you, Charlie. Thanks for your kind introduction. Everybody can hear me all right?
Sounds good.
All right, good afternoon, everyone. As Charlie said, my name is Nini Mishra. I'm Informatics team lead in Surveillance and Data Science branch in Division of STD Prevention. In past, I've also led the COVID-19 contact tracing team, contact tracing and innovation team, and I might be heading back there again soon. So I bring perspective from both these worlds, and that's why I wanted to provide some contextualization today. So in response to COVID-19 pandemic and other outbreaks, public health officials have often expressed desire to have such connected systems that at least connect laboratory and case reports to surveillance and contact tracing system, including customer support systems. And ideally, such a system would thus integrate data across laboratories, state surveillance infrastructure, and even healthcare, although healthcare is further out. And hence, we will have relevant infrastructure to support our caseworkers, be it a contact tracer, a DIS person, or a case management official. So coming back to the STI HIV world, where we come from, we know that while number of STI cases are growing, resources available are not. Though, as Charlie mentioned, there are a number of other places from where resources could be available. So it seems that to address some of these challenges, we in STI world will have to think in a creative and innovative fashion. Only then we can take advantage of data and system modernization efforts happening all across public health at different levels of public health. And also, perhaps this is a good time to think about technique and processes we have used in our domain, STI domain, for decades now. And they now could have a broader applicability for situations like COVID-19 response and other similar outbreaks as well. So it's a bidirectional exchange of expertise. So to facilitate these kind of discussions and to bring innovative ideas to the table, DSTDP has partnered with NCSD to conduct webinars on a variety of topics. And last time we met as a group, as perhaps some of you remember, we had invited a participant to talk about how cloud-based systems could bring efficiency to public health. Now, this time we will take this a little further out. And today we have invited Jim Ivey from Checks Out, who would be talking to us about how Checks Out, that started as an STD clinic software, is being used across different disciplines and even for COVID-19 response. So that shows that we have a lot to offer, a lot to share, especially with regard to how our DIS workers have gone out and traced contacts and cases. So with that, Jim, I hand it over to you, and we are looking forward to your demo.
Thanks, Dr. Mishra. Thanks, Charlie. I want to thank everybody for joining today and taking a few moments to look at the Checks Out software platform. Let me see here. Let me share my screen. Charlie, can you enable my sharing, please?
I'm working on that.
So Charlie's working on that. I'll give you a little background on Checks Out. We started Checks Out about 10 years ago, and we work exclusively with public health. We have clinics that we work with from Hawaii to the US Virgin Islands. And we started out as a results notification platform, and then through time and through requests from our customer base, have evolved the software to integrate everything from clinic management, where we can operate as like an EHR specifically built for public health, dynamic patient communications via text and email, and integrated VoIP. We've also built a very thorough platform for investigations and contact tracing and outbreak management, which came in very handy when we deployed the software for use during COVID. So I'm going to talk a little bit today, show you a few slides here, and then I'm going to do a very quick demo of some of the higher features of the software so you can get a feeling of what it all looks like when all this comes together. So what are some of the things that we learned from COVID? And a few things that we learned are that we need to have our software platform be able to support multiple program areas. For instance, being disease agnostic, and they need to be rapidly configurable for new infections, and need to be able to emerge with new emerging technologies, right? So we also need to be scalable for both your workforce and data transfer mechanisms. I can't tell you how many horror stories we heard during COVID of electronic disease surveillance systems failing because they couldn't take more than 600 lab reports an hour. We know now that a software system should be able to take 60,000 in a few minutes or 100,000 in a few minutes in order to be able to meet the need of a future pandemic. We also need to be able to easily adapt to new requirements, feature development, emerging technologies. When we launched our new platform in 2020, just before COVID hit, we had spent years building it from the ground up so that it would have the newest architecture and the newest thoughts in how to integrate multiple program areas and how to bring information together and make it usable. So we didn't just slap new paint on an old software system. We actually rebuilt it so we can meet today's needs and tomorrow's. And you also need to be, you're looking for software that's data agnostic. One of the things that we found in every place that we've put software, deployed software, is we have to work in an existing ecosystem. So knowing the client's ecosystem and being able to work with those other data systems is key to having a successful software launch. And we call that play nice with other systems, right? That one should be common sense right there. So ideas to apply some of the lessons that we learned. We like to say to avoid open source software that only performs one function well or maybe a few poorly. Oftentimes health departments look at open source software and think it's amazing because it's free. Well, in a lot of cases, it ends up costing you more in the long run because these softwares weren't built to work together, and it can cost a fortune to keep them running and to get them interoperable. And avoid legacy systems that are reworked to meet yesterday's needs. Like I said, new coat of paint does not mean it's a new software system. And we like to stress that you want to avoid software that still requires your staff to perform critical functions outside of the platform. When we built the new Checks.Out platform, we spent a lot of time in clinics working with DIS, trying to learn all the things that they needed to do in order to complete an investigation. And we were horrified to see that, more often than not, they're having to work with 4 different data systems, inputting information that's different into each one, and still having Excel docs on the side. So we built the software to do everything in one piece. And then we learned this in COVID, it definitely avoid systems that are still in build mode or big box software not originally built for public health. If it's a customer relationship management software that was built for a different sector, just changing a few fields is not going to make it public health software. So what kind of things should be in an integrated disease platform? Like I said, our view is that everything should be integrated from the clinic, where you see patients do testing, outreach testing, mass testing events, through your investigation and contact tracing, working with labs, ordering lab results, taking lab results, electronic case reporting, and then also your overall surveillance activities and reporting. So we have some of the features here listed out. I'm not going to go through each one in the effort to save a little time here, so we have more time for questions and answers. But a couple of things that I want to point out is I want to point out this one right here: interoperability with other data systems. Checks.Out's data agnostic. We can take whatever a customer needs to send us, and we can utilize that information. So I think that that's very important for having a successful software. I spoke a little bit about our vision for integration, but here's another layout of how we all see that work. Clinic management, the automated patient communications. For instance, we found during COVID that if we text a patient immediately upon starting an investigation, saying that this is the West Virginia Department of Health, we will be calling you in 24 hours from this phone number, that increased the probability of patients can answer the phone by about 90%. So utilizing a dynamic communications platform that's built in is very effective. And it's also superior to using cell phones because cell phones are unsecured data sets. And this keeps all of your communications in one area so that, as you can see when I show you the software a little bit, you can work collaboratively because you can see the communications that other staff members have made. So having it integrated to the platform itself is very, very important. Having investigations integrated, and data management, and of course, then your surveillance activities. So not gonna spend a lot of time on that slide. So like I said, to understand the client's data ecosystem, one of the things that we do is we worked enough with public health that we've seen, just about every iteration of ecosystem that we can come in contact with. So we built our software to be flexible enough that it can fit into places where you need certain features, or it can come in and we can do everything from top to bottom and completely replace the system. And part of that is, just, playing nice with other software. So I'm not going to belabor the point here. We can always talk more about that in the question and answer portion. SaaS and cloud infrastructure. This is very important. And a lot of health departments have moved to software as a service and cloud infrastructure because it includes a lot of benefits. For instance, you have the ability to run from a browser on any device. You have on-demand scalability to grow your staff or to grow your data intake and output capabilities. They're all scalable very easily with cloud infrastructure. Also, it gives you ability to respond better to outbreaks. If you have changes in staff and you're working on software as a service, you can just spin up more staff on the available seats. That's one thing that we do is we let you reuse seats. They aren't tied to the actual individual user. So when you have churn with staff, you just put new seats in. And then also, we all know that clinics like to change things a lot. Not clinics, the labs like to change a lot of things in the data transfers. And sometimes we have to change labs. So being in a SaaS environment, cloud environment allows us to better, more quickly respond to those changes. And we can be your tech support team, right? We know that public health has a limited resources in the tech side, so that gives us the ability to be your tech support team. Now, all that said, Checks Out can run both as a software as a service. It can run in our cloud, it can run in your cloud, or we can deploy it if you still need to have hard metal servers on site. The software can run on site too. So Outbreak Management has become really big part of our software system. And it's where all the people and places start to meet, and we are able to take that information and alert your staff when you have, 2 clusters that may be connected by a place, or if a certain place has been named N times during X, N people have named X place, let's say N people have named some bar 10 times in the last 2 days. The software can alert you that you have a potential outbreak in your community, so you can quickly and effectively deploy resources. So Outbreak Management is a key point in our software. And then we have advanced investigation and contact tracing tools. So you not only have the ability to run your clinics off the software, your mass testing, your outreach testing, but then you can automatically move a patient into an investigation, and you can, we have tools for quickly bringing in data from other data sources, distributing that information, automatically assigning investigations, and making sure that the data gets to where the data needs to be when it needs to be there. And one of the big things that seems to be a hero of the software these days is our dynamic and interactive cluster diagrams that allow you to view your clusters and information about each patient. I'm going to show you that live. So more about the features that you should expect with investigation and contact tracing. We talked about auto-signing by patient demographics. I think that's a huge one because it saves a lot of work time. Some software systems try to tie you into their VoIP system so you can make calls to the software. We don't care. You can use ours. You can use your own. And we have a customer that built a library, 22,000 locations. They loaded into our software so that their staff could very quickly add places so that our outbreak management software could be used at its maximum efficiency. So we're going to just keep on moving through here. We talked a little bit about patient communications. And I think that, don't want to spend too much time here because we're going to talk about it when I show you the communications module in the software. So we're just going to keep on moving. So I want to talk about a few of the instances where some of the tales from the trenches, the COVID-19 trenches, right? With West Virginia, they contacted us in May of 2020, and they needed the software live in 30 days with a base set of customizations, and it needed to have the ability to scale to 1,000 contact tracers, take in tens of thousands of records a day, distribute that information, and make it usable across the entire workforce that was working from home. We met that requirement. We've continued working with West Virginia, building more and more features for them and designing the software to be more specific to their internal workflows. And at this time, we are continuing to work with them. And the plan for West Virginia is that we will be replacing West Virginia EDS in all of our program areas and integrating all the different functions that fall under the health department so that everything is fully integrated. In Indianapolis, when they purchased the software, they had the NCAA basketball tournament fast approaching, and we had 23 days to get the software up and running, very similar to West Virginia, except they needed us to act as a data hub for their other software systems that they had to interact with. And that included their public health laboratory, their state's Microsoft Dynamics system, another third-party vendor. So again, the ability to move data and utilize data is key to creating efficiencies. And the software, when we can become that data hub and we can integrate more pieces into the software, breaks down information silos and creates efficiencies. Philadelphia is a very unique scenario where they're a long-term customer of ours for their STD program, where in the city we not only support their clinics that they run, but we also support 87 testing sites run by community partners, including their all their school-based testing programs. So with COVID, they had a pretty well-developed ecosystem, but they needed some gaps filled in that the other vendors couldn't help with. And that included running their mobile COVID testing vans with online appointment scheduling, immunization appointment reminders, and now we're running their mobile vaccination vans. So you can see that, it's not just what the software can do out of the box today. More often than not, we have customers call us with, is this possible or is that possible? And the answer is normally yes. We can do custom builds and meet very specific requirements. So I'm going to do a brief demonstration of the software. A couple of things we're going to point out are the collaboration tools, investigations, patient communications, cluster diagrams, and outbreak management. Right. So I'm logged into my software here, and a couple of things to point out. We built the software to be one giant platform so that you can see visits, investigations, outbreak management, workforce management. They're all here. And what you have available to use based on your role-based access and what your health department wants to purchase. And one of the good things about having a software system that's like this, that is integrated into so many parts of the health department, is if we have another coronavirus or another virus, another pandemic come along, you'll always have your software in a state of readiness. So the very people that we're going to entrust with going out there and attacking the new virus, our DIS, you'll have already trained on the software because, if your STD program's using it, you can, or infectious disease program, we can quickly, within days, spin up a new investigation in the software, investigation type, to support any future infections that we come across. So I think it's very important to remember that we can have software and we don't have to next time have to go out and find these tools. So this can meet all those requirements. Something to note here is our task box. I always like to point this out because the software was built to be collaborative. We know that, for instance, I'm Jim Ivey, I'm working in investigation, and I'm talking to Captain America, and he can't speak right now, but he can talk at 6 p.m. I could message Joe Paulini through the software and say, hey, Joe, can you call Captain America for me at 6 p.m.? And a task will pop up in the task box. Also, for doing something like symptom monitoring and a patient has a certain set of symptoms, it can alert me to those symptoms. So I can also set tasks for myself. So this is core to our ability to manage that collaborative work environment. It also allows us to send to a supervisor or regional epi an investigation for review. So they know they need to review it. And of course they can send that back with notes. So this is a very core piece of our software. And then other things are going to populate based on your role. I'm not gonna get too much into that. With visits, like I said, our visit software can run a clinic from end to end. We have a patient portal that has custom post-test counseling information. We can do mass testing events, and it can also run, for instance, Philadelphia is going to 10 pop-up locations. In addition to their mobile testing vans, it can run those types of things and your outreach testing programs all under one roof. You can literally just pick up the same tablets you have in the clinic and take them out in the community wherever you're gonna do testing. The incoming files, think of it as like an inbox, right? So we take data from sometimes dozens of sources for a customer. Those could be the public health laboratory, different labs, maybe coming from the state electronic disease surveillance system, you name it, we may be taking that information in. We can create incoming files that normalizes that information and then allows us to take it and assign the patients out based on patient demographics, infection type, whatever it may be, to help your staff save time on getting these investigations to the appropriate DIS. So if I have a visit, I can, and I have a patient that I presume to be positive, I could go ahead and if I wanted to, when I'm with the patient doing my visit, I'm like, okay, you definitely have gonorrhea. I can go to partners and I can go ahead and start capturing my partners in contact by referral basis here if I wanted, or I could create an investigation and it can be assigned out to a DIS immediately. So that's one of the good things about having that integration. And then all the data will flow from the visit to the DIS that needs to do the investigation. So when I come into my investigations tab, you'll notice I have a lot of information at the top level, but you can also see this red bar here. The software will let you know if you don't take action on an investigation within, say, 24 hours or whatever it is for your health department. So we make sure that nothing gets missed, and we can point out more efficiently some of the patients that need care. So I'm going to jump into Captain America and just show you a few points here. For Captain America, you can notice in our software, we built it so that everything is on the top level so that it's very tablet friendly, it's very user friendly. So everything you need for an investigation is in one place. I don't want to spend too much time on getting into the details of the software other than hitting some high points. So let's talk about the communications module. Here, I can send a text if I want to do it manually. I can select a template and you can standardize these templates. We can click on it, we can come in, we can change, we can put my name in here. You can also have it in multiple languages to help you communicate with patients that English may not be their first language. So we can send messages, all messages are compiled. We can send emails, log calls, log visits, call the patient right from here. So it's a very dynamic patient communications module that supplements or goes alongside of our automated communications that we can set up for you. When we are running our investigation, so one thing to note, you can see our Ring Central app here. I'm not logged in, but that's our integrated VoIP. You can also click on the patient's phone number to call them. And if you have your own VoIP, don't worry, we can integrate with it because we want to be able to work seamlessly in anybody's ecosystem. So I can collect information like demographics. It's kind of nice to know what the person looks like when I'm going out in the community looking for them. But the real meat and potatoes of the software is our ability to, one, collect custom risk factors. We can come in, collect, whatever applies. Save that information automatically saves when I leave the module. We can collect attached notes, attachments, PDFs, whatever. But what I really want to get to is our partners and contacts. So I'm talking with Captain America, and we can see I've already collected some partners for Captain America. I can click open any of the partners that are listed for Captain America. And for instance, for Agent 13, I can open it up. I can see that she prefers to be called Sharon Carter. I've got a phone number. I could call her right from here. It would open her investigation with a call log, so I can take notes on that. But I can also see any other contacts that have been made so that I can say, oh, she was called today by somebody else. So, I don't need to worry about it. So I can always see my contact history. One of the principles of software is to bring all the data we can to the top level so that you never have to go looking for things. Now, when I add a contact, I can just come in, pick my referral basis, and it'll open up and I can collect any information that Captain America has on this new individual. And I'm not going to go through and enter information, but we can also collect risk factors, things that may help us find the person. Like we have a few text boxes here for tracking, just information on where you may be able to find the person. We can collect where they came in contact with each other. It was very important for COVID. You can also see the cluster diagram from the new individual's perspective. And I'm going to get this in a moment. And if I'm talking to Captain America, I don't have to go back into his investigation to add more contacts. Click this, add another one, another page opens, and I can just keep moving as fast as Captain America can give me his contacts. So back to partners. You can see here that now we have a new partner, and we're going to talk about the cluster diagram. So we built the cluster diagram to allow health departments and allow our DIS to visualize their investigations. We color coded them, and we put the ability to open them up and see information and mouse over and see what would be in that investigation important to you without you having to go into it. For instance, I could mouse over Scarlett Johansson. I can see she has a syphilis positive that's about a month old. I open it up and I can see, 10 years ago, she had a positive HIV test. So I have a comorbidity there. So that's one of the great things about this is red, we made it interactive and we bubble up the information at the top. Red indicates a positive test, green would indicate negative, and blue indicates that there is no information yet. And it will show you the referral basis for each one, how they were connected. So this is a great tool here. Then also I could come up and I can add, I guess in this case down, I can add places where people have been. In the software, we can create a library system, right? So I could put Sakar, the Trash Planet, put when this person was there, add it, and then it becomes part of the history that we can now search. And the software will tell you, if you search on this page, how many people in this cluster have named each place during a specific time frame. So that's a very valuable tool. Then if we go up to our outbreaks tab, we can see all of our different outbreaks, right? You can see Avengers Tower. I can open it up. I can see, plus have a link to each individual by investigation, by contact, who's associated. And I can also see anybody who's named that place, but isn't necessarily a part of the investigation or hasn't been made part of the investigation yet. So the software is going to go out and look for whatever information you need to help you make the decisions on who should be in an outbreak and who shouldn't. And then with our places list down here, this allows you to search the entire software system for anybody in it who may have named a place during a period of time, so that you can quickly identify new outbreaks that are happening. The software can also tell you if a certain number of people name a place during a certain time frame, alert your outbreak manager, and we have more tools around the outbreak manager role as well. I also like to talk a little bit about, we have workforce management tools in here. Especially, it's important when you have a lot of staff that are especially dispersed or not necessarily GIS, work investigations, like during a pandemic. And we also have our Analyze tab that allows you to come in and quickly view information on tests that were performed and notifications that went out. And we'll show you an aggregate view so that you don't have to go looking to see if the gonorrhea test came back. It will tell you everything in one place. This is one of the favorite tools that we have. So you can see here where we've taken and we've brought everything into one place so that you can run a clinic, you can run testing, you can communicate with patients. You have a patient portal for notifying patients of their results and getting them educational materials. You can quickly move that into an investigation, work your investigation, collect all of your information, including things that you just want to collect because that helps your investigation. They aren't necessarily reportable. You can capture your contacts at any point. When you're talking to the contact, you can collect information from them and contacts of theirs. Then we can have all that information bubble up and it can be displayed or exported for reporting surveillance purposes. Another thing that we found that's been very valuable is our health departments want their data. It's your data. And you have, a million different ways you may want to crunch that data. I'm not an epi, so I can't imagine all the different ways, but I can tell you that what we found is the best way to get our customers their data is we set up a read-only replica of the database. And we found that's been very beneficial because our health departments can then run their SaaS software against it, or they can run SQL queries against it, and it gives you unlimited access to your data in real time, right? Because that's really the goal of all of this, is to collect our data, get our patients into care, and then utilize that information. So that is my quick overview of the software and how some of the higher level functions work, some of the heroes of the software. I'm happy to take some questions. I think we have about 10 minutes here for questions. So I'm going to open the floor up.
So Jim, thanks for a great presentation showing this comprehensive software. We have a really good question I think applies to a lot of people. And the question is, how do people use this data in conjunction with other reporting systems that they're required to use, such as Cal Reddit? Does the documentation have to happen in both places, or does one system feed into another system?
Yep.
Same with already existing with EHRs. So can you talk a little bit about how this interfaces and how you can import and export data?
Yep, thanks. And that's a question that we get every day on every phone call. So what I talked earlier about being data agnostic and being able to understand and work in a customer's ecosystem, that's what I was talking about, is our ability to work with your electronic health record or your electronic disease surveillance system like CalReady. What often will happen in a scenario is, for instance, like in Indianapolis, their state system, electronic disease surveillance system, will create an investigation coming from some other source that will come down to us. the investigation will be worked in our software, and then the information required for that to complete a case in their electronic surveillance system will kick back up, and we can import a file into the software. So it just really works like a front end. But we are happy to, and we have a lot of experience setting up the back and forth data flows to make sure the information gets to where it needs to be. We often work with EHRs. I probably could name 10 or 15 that we've worked with that most everybody's used. And EHRs are a little bit more tricky because a lot of them aren't very friendly at taking information back in. They really don't like to work with you on that. But we do have the ability, for instance, if you have an EHR that doesn't have some of this functionality to sit behind it. For instance, in Philadelphia, they don't actually interact with our patient notification software. It sits behind their EHR, and we work with their public health laboratory to do the notifications and to get patients their results in the patient portal. So we can't set up one-way data flows and accomplish a whole lot on our side to help free your staff up.
Great. Okay, Mary wants to know, does the Outbreak module work throughout the system and not just within the person record? So if another person not named as a contact names the location, will they also be included in the outbreak?
So that, the way the Outbreak module was designed is it works off of two functions. One, when we're in investigation, we can name all the places that this person has given us. And we can also go in and manually assign that they are part of this outbreak. Now, if I don't want to go in and manually assign them to the outbreak, I can always come in to my outbreak tab, and anybody who's named a place, if they're part of the outbreak, they've already been associated, they'll show up under your references here where you can see Captain America, Robert Downey Jr. They're all part of the outbreak. But then I have references associated by place, which will let me know anybody who we know to have been at that location during that time frame or outside of that time frame even, who hasn't been made part of the outbreak. You can come in and assign them from here so that you don't have to go looking through different records trying to figure out who may or may not be a part of it. So yes, it does go across the entire software, and it looks for anybody who may be a match, and it brings it up for you so that you can quickly identify whether or not they're part of the outbreak.
Great. Okay, Captain America's assistant in Vermont wants to know, if an index patient names a series of contacts and you enter them, does that index patient automatically map onto the contacts if the contacts end up testing positive?
Right. So if I understand the question properly, when we're collecting information on all the contacts for Captain America, the software knows that Agent 13 was named by Captain America. And we also know that if Agent 13 names Captain America, it will come back as well. So we always keep all those epi links wherever. And if a contact gets a positive lab result, the software will automatically turn them into an investigation. And then we can have some of the rules around how they get assigned come into play. Did that answer the question?
Yeah, anybody, if you ask a question and it's not clear, just ask a follow-up and we'll be glad to take it. Somebody wants to know, what type of incoming files does the application consume?
We can take HL7, we can take flat files, we can take CSVs, we can take XML. If you can make it up and you stick to it, we can pretty much take it. We are very data agnostic because we understand that all the different software systems, some are legacy, some are new, the health departments work with all have different, sometimes different standards. So we are 100% data agnostic.
Great. Okay, Ryan wants to know, how often does the read-only data set update? What type of question types can checks out handle? Check all that applies, selection choice, repeatable question, etc. And what is the process like to add new questions or changing existing ones? So I know that's a mouthful. If you want to take one piece of it and I can re-ask one at a time.
I got the rest of it, but I lost that one.
All right, I'm going to start in the beginning. So how often does the read-only data set update?
Got it. So the read-only data set can update as frequently as we need it to. We generally run it about 4 times a day, but we can make that go every minute if that was something that were needed. And then I think the next question was about what kind of information can checks out take and what type of data fields. That's a great question. I can answer it here under risk factors. We like to keep the user interface very clean. So we do have the ability when you come in and click, who do you have sex with? Everyone, right? Click out of it. So we did a select all to apply. And then, for instance, here, we can do another select all applies, right? And one thing I want to point out with the data field is when you close it, everything bubbles up to the top level. So you never have to go back in to find the information you enter. It's always going to come to the top level, even for select all applies. So we can do dependencies. We have, for instance, questions that will open up another question. And if you answer yes to that question, it'll open up another question. So we have a series of dependencies that are all based on, the outcome of what the patient's response is. And we like to keep those hidden behind so that we keep the user interface clean, and then we can help drive those questions for our investigators.
What's the process like to add new questions or change existing ones?
So the process is we become your tech support team, and it's best if you call us and you say, hey, Jen, we need to change. We got new guidance from the CDC, and we've got 25 new fields that need to be edited. We'll go in and edit those for you. We are an agile shop. We would like to, if it's not a critical item, stick to our 2-week deployment cycles. But if it is critical, I think West Virginia can attest that if you need it done in 24 hours, we can make it happen, and we've done it before. So it's a very simple process. And one of the reasons why we like to control that as opposed to making that facing the customer is that a lot of fields in the software have dependencies and have calculations behind the scenes, and we don't want to go breaking things. So when our staff can make those changes for you, it ensures that we don't have anything get broken and no mess get created.
So is that also the same for variable choices, not just questions, but if somebody wanted to add another variable, they need to work through you guys to do it, right?
We would prefer that you did. We do
Okay.
have a factor generator that would let you do it, but I would just suggest working with us.
Okay. Is there a pilot instance to play around with?
So when we go through the contract process and you decided that you want to move forward with us, and we get the contract in place, we will give you a sandbox that you can work with to go along with the data dictionary, so that you have both to look at and work through the software and try to see what pieces you like and what other pieces you may want to change. So yes, we do have a sandbox available.
How long would you say, like if somebody wants, to set up a system and customize it, what's the deployment time from starting to talk to you to getting it live, would you say?
After the amazing public health procurement timeline, once that's out of the way, it just comes down to us working with your team. We can meet really short deadlines if we have to, like we did in COVID, but preferably we would like to be in that 3-month setup timeline. That would include, the software configuration. Everybody needs some customizations because everybody's got a little bit different way of doing things. Allow us to, build in some custom reports for you, and then, get it deployed, in a very logical, not rushed manner, right? Now, if we're going to be doing massive changes, it could take more than that. It could take 6 months, or in some cases, you might push out to a year if you really wanted to blow the software out and have all sorts of bells and whistles built from scratch.
Okay. Is there an option for special projects or build-outs like a congenital syphilis wizard or expanded interviews?
Yes, we are happy to custom build just about anything that you could want to have in the software. Most of our features come from customer requests to build something, and we build it for them, and then it becomes germane to the software, and we make it available to everybody. So that's one of the benefits about having the software as a service version of the software, is that we do at least monthly updates, and you will be getting new features and little optimizations throughout the software as they are built for other customers. So yeah, we're happy to build anything that you can need.
Okay. Does ChecksOut support case notification data transmission to CDC?
We do. We're presently working for, we have the COVID taken care of, and then the next on our list for the reporting is for the STDs. Okay.
If a project area wanted to do like an MOU with surrounding areas or other programs, is that a possibility? systems work together?
Something that we actively encourage. We like when health departments can share information, within the set of rules. And if that were a case that we could set up, we're happy to bring those different entities under a parent account. So you have a parent and a whole bunch of children accounts where we could put specific rules pertaining to each, to each agreement that you have, and then you can share information.
Okay. This is kind of a hard question to answer, but what's the cost of checks out? How do you kind of stratify that?
We price it in two different ways. For very, very small clinics for STD, if you're just going to run the visits, which is what a lot of small clinics do, it'll be as low as $4.99 a month. But when we get into the larger deployment of the overall platform, we're talking $159 a month per seat. That's only paid on an annual basis, and then setup is going to be based on how many changes you want to make out of the box and how big your wish list is.
So was the
very cost effective.
So was that $4.99 or $499?
Yeah, something like that.
Okay. Can it perform deduplication of events and persons?
Yes, we have very advanced deduplication features in the software that we really maxed out during COVID because we had so many patients in the software. We had parents and we had kids that had the same name. So when you come in, you can, I can say I got Gwyneth Paltrow here. I can search. I can see the one that I'm viewing. This isn't a very good one. Let me find a patient who has a more, let's see, Dave Buisa may have there may be another Dave in the software. No, there's not. So if there were another Dave in the software, I can see the one that I'm currently viewing and it comes up red. Any other ones, any other patients will show up underneath it and it won't have that red background. And then you can come through and you can see if you have a potential match. And we have multiple ways of connecting and deduplicating that allow you to, just connect and say that these are two different records or they're duplicate records. And we also are bringing in the next update a new logical deletion function that doesn't allow for actual deleting. It just hides it in the background so that we can get data out that may be bad.
Do you have a base system that a state would just build upon, or does each state have to build from the ground up? If one state likes what another one has, is that something that can be implemented?
Yes. So we do have a base system that we have here, and it's kind of what you're looking at. And then, for instance, if one state looks at another state and said, hey, I really like what they've done with their workflows to cut some time down, we can spin up that as a base version and work off of it. But no, the one thing we never want to have to do is come in and hand build you software from the beginning, because that takes years, and we like to be live in months, not years.
Okay. And if anybody's having any problems writing in the Q&A, just write your question in the chat, or even raise your hand and we'll try to call on you. About how many different states would you say you have checks out deployed in?
With all the different versions and types of deployments we've done, I think that we're in 16 states now and territories.
Okay. And if someone is interested in working with you, what's the best way to get a hold of you?
The best way to get a hold of me, and Joe, if you could post in chat my contact info. You can either email me or give me a call. I'm a phone person. I much prefer to chat than send emails back and forth. But yeah, just reaching out to me is the best bet. And then what we'll do is we'll set up a time for a demo and work through some of your expectations for your program, some of the things that you'd like to see the software help you with, and then we can just move from there.
Great. Joe just posted your email address. I think your contact information is also on your slides that, again, they're downloadable in the chat. And if you can't get them in the chat, just put your email in and email address in the chat and we'll send it out. We know a few people have had it. All right, so we have time for about one more question.
Charlie, I have one more question from somebody.
Sure. Okay.
If my jurisdiction wanted to put the purchase of checks out in our DIS expansion grant, how much should we budget for?
Well, the seat cost is $159 per month per seat, and that's just that's a hard cost, I can tell you. Then we would just need to sit down and have a quick conversation about what you would like to change in the software beyond what's presently available, or what your setup costs are going to be, and then we can get together a setup cost for you, and then I can give you an exact cost. But yeah, that just takes a little bit of a discussion.
Great. Well, that kind of wraps it up for Jim's presentation. We really, appreciate that. As always, NCSD and CDC don't endorse particular vendors, over another, but I think your product, does meet a lot of people's needs, and I think people should look into it as well as, anything else to see how we can improve our surveillance system. So, again, if you have any other questions, feel free to write them into the Q&A, and we'll try to take them at the end of the meeting or send out a response. I do have a couple of quick poll questions I'd like to ask. So first of all, if you could give us some feedback on today's meeting, just in general, whether we thought it was excellent, good, fair, or poor. And we'll give you about 15 more seconds, and we have one other poll question. Okay, so I'm going to go ahead and end this poll question. And just, here's our results. And if one of our facilitators could do a screen grab of this, it would be helpful. So really, it's really encouraging. Almost 92% of you thought that today's webinar was good and excellent. That's why we put these on, to be helpful to you. We want to help you to have the best informatics and surveillance systems as possible. And then our second question, if I can get this up. Was this webinar worth your time? I know everybody's super busy and there's a lot of demands and a lot of programs out there, but whatever we want to do, we want to make sure it's worth your time. I don't think anybody has any time to waste these days. So if it wasn't helpful, let us, if you're answering no, if you could send us a note, either anonymously, or feel free to email Robin or myself, and I'm going to show you our email addresses in a minute, and give us some suggestions on how we can make these meetings more useful for you. We'll give this about another 15 seconds. So it's great that 96% of you said that you felt like today's was worth your time. So that's great to hear. Again, I'll share the results. And again, if one of my colleagues can grab this. So our last slide, again, here's the results. Is NCSD and CDC are trying to do these informatics webinars about twice a year. We'd love to know what you want to know, what you'd like to have presented. So if you have topic suggestions, cloud computing, software as a service, how to link different data systems, if you send Robin or myself an email, we'll see what we can do as far as getting that scheduled out. We do plan on having our semi-annual user group meetings for Maven, Prism, and NBS, probably sometime in October. So really want to thank our presenters, Jim and Ninad, and all of you for taking time out of your busy schedules to attend this webinar. And again, NCSD thanks you for all the great work you all are doing, especially under these difficult times. It's I think public health it's amazing how undervalued it is. And I think it's just, COVID has really just shown the importance of, and the heroic work all of you do. So stay safe out there, and thank you for attending. That's it.
Thanks, everyone.
Okay, looks like we made it.
We
Were
did.
you able to grab those poll results?
Yeah, I took a picture of it with my phone because my screen
Okay.
grab wasn't working on my computer, but I have a
Okay.
picture of it.
Okay. Yeah, I can grab them from the data, but it's just, you know, it's so much easier. I don't know why it doesn't show that in the reports, but whatever. Yeah, I don't know what happened with that download, because usually I haven't seen that really as a problem. So
I think maybe people have old versions of Zoom. That might be it, because there's only a few people that were having that
Okay.
problem.
okay.
So
Yeah, I told Talia I saw them just fine, the slides.
So yeah, I grabbed the emails of people that can see it, and I will send them out in like 5 minutes.
Anything, you know, I didn't realize, like, once I got into it, I had my screen full screen and I couldn't see myself or anybody else. So yeah, I forgot to put it off of full screen, because when I'm screen sharing, that's all I see. And there's a way to get around that. I just, you know, forgot. But I thought the Q&A worked well. I didn't see, you know, there were a few people that wrote questions in chat, and you know, I think we were able to grab those. So I was pleased that we had a lot of questions.
Yeah, that's great.
And a lot of attendees.
Yeah, how many was that? I didn't even, you know, I got into it. I didn't even notice.
The highest I saw was 108.
Yeah, it's kind of what I feel. Usually about half the people that register show up. But that's great attendance. And you know, I know it's a little bit hard. I think people probably feel a little bit obligated to give a good rating, but you know, if people don't like it, they'll rate it low. So I think we got very high ratings and stuff. So
Yep. And I saved the chat. I have that. Is there anything else that we need to grab before?
Can you grab the attendees, or I don't know if there's a way here to do that. I think we might have to go into the back end.
Yeah, I don't know how to do that. I think it's on
Okay.
your account.
Yeah, okay, I'll have to look. So
Well, guys, I need to jump off. I need
Okay.
to do something else, but I think this was really good. Thanks so much.
good. Thank you, Robin.
Talk to you
you.
later.
Bye.
Okay.
Bye.
Anything else, Talia?
I don't think so, unless you have something else. I'm all set. I will send you the chat now. I will send out that email to people that can access the slides. Yeah.
Okay. I think
job.
there's a way. I think there's a way to save the Q&A too. I mean, I think it's saved. So, you know, again, we'll have to think. Maybe that's something we can put in our TA.
That's true. We'll definitely report it in the NX grant report. Are you going to send out a, I know we did the poll questions at the end. Do you usually do a evaluation at the end too, like a Survey Monkey, or no?
No, because I kind of found like just this, you know, a lot of people don't fill it out. And if I can just ask a couple of questions now, I can kind of grab it. And that's kind of what I report out on Nexus. So, I mean, yeah, so that works out fine.
Yeah, okay, sounds good.
Okay. I think Zoom has recently updated their, so you can do survey stuff right out of Zoom now at the end. Instead of,
That's
you know,
cool.
it gives you the option. You can either do Survey Monkey, which does have some power as far as graphics and that kind of stuff, but you can actually ask questions. The only problem is I kind of hate how it throws it into Excel, and it's kind of hard to grab the data out of it easily, but it's doable. So,
That's cool though.
well, appreciate your support, just having somebody kind of covering the back end.
Of
You know,
course, my
it's
pleasure.
kind of hard to do 10 things at once, so, but,
Absolutely.
okay.
Happy to do it. Alrighty. Well, I will
Good
talk
job.
to you later and let me know if you need anything else. Great job. I'm sure you're
All right,
relieved
thank you.
it's done.
Yeah, it'll hit me in about 10 minutes, but
Yeah.
we made it.
Yep.
Okay,
All right. I'll talk to you later.
see you, thanks, bye.
Bye.